Okay, it's okay. Maybe I can ask. Makioto, could you talk to me about tuberculosis? Just random facts.
Hello. Sorry, I had stepped out for a minute. Could you pardon the question?
Talk to me about, tell me just what you know about tuberculosis in general.
Okay. Maybe I could say the cardinal features.
Mm-hmm.
You'd have, ptosis, chest pain,
Mm-hmm.
uh, sputum. Then there's primary and secondary TB. TB can cause sports disease, causative agent, Mycobacterium tuberculosis. Uh,
Mm-hmm. I don't know if that's a problem on my end, but Keith, can you hear Makioto anymore? Mhm. Okay, I think there's a problem with the connection. Hi, Makioto, we can't hear you. But okay, so far what she's given us is okay. Um, um, Tuberculosis is an infection. It's a disease caused by infection with the Mycobacterium species. And it's important that we know it. We know how to approach it in the world because TB is multisystemic. These conversations that we have are more or less to help us approach multisystemic conditions. And we're going to do this together. Once again, guys, I'm not saying that in any way. Yes, I've seen somebody. Linda has talked about drenching nitrates. Uh, yeah, so that's okay. So it's important to know that TB is a multisystemic condition. And when you get this disease, there are a couple of things that happen. So when you meet a patient in the ward, most likely sometimes you'll meet them across all the wards. So now let me ask you guys, okay, who remembers their pathology lecture on tuberculosis? Maybe I can just go around and like scope and ask. Tell me everything you remember about that lecture. Because I don't know. There's somebody very characteristic who taught it. I don't know if he's still the one who taught it to you guys. So maybe I can find out. Um, Angel, could you tell me what you remember about tuberculosis from pathology?
I remember that tuberculosis, the main cells in the body that that are used in fighting tuberculosis are the T lymphocytes. It's a
Mm,
type 4 hypersensitivity reaction.
wow.
There are formation of granulomas, which have
Mm,
the T lymphocytes, the epithelioid cells surrounding. These are all types of macrophages that surround the granuloma and the fibrous tissue at the periphery. There's, I think, necrosis, sorry, that forms like the cavities in the lung.
mm,
So the inside of the cavities is filled with like a cheese-like substance. That's
mm,
what I read. Yeah. The some of the tuberculi, the bacilli, sorry, lie dormant in the granulomas, then they reactivate later if there's immunosuppression of the patient or they're taking corticosteroids, something like that. But also the type 4 hypersensitivity reaction is what is the basis of the skin test. The Yeah, okay.
That's
That's
good.
all I
That's good. So now what I'd like to add on your knowledge on that, Angel, is that when you're describing tuberculosis, have this idea in mind. So in mind, you should have the idea that you have primary TB and you have secondary TB, yeah? So when you approach TB, try and think about it like that. You have primary, you have secondary. So you've done it well. You've talked about the gross pathology and a bit of the immunology involved, and that's good. So you have to always remember that TB as a disease has a primary and secondary. And in primary, there could be primary progressive tuberculosis, or they could just be primary. And then there could be secondary tuberculosis that could be due to reactivation of latent infection, or you could have secondary tuberculosis secondary to new infection in a previously immunized but currently immunocompromised patient. Yeah. And so now let me ask a question. This is a common MCQ question that used to appear in the patho MCQs, if I can remember. How is TB transmitted? Like, no, how does TB move from like the lung as its primary area to the other systems in the body? Maybe I can ask Ian that question. Ian, could you tell us about how TB will spread from the lungs to other tissues? Is Ian speaking right now? Yeah, Ian, it's okay. But I've seen somebody has talked about direct spread, hematogenous, lymphatic. That's very good. That's all I needed to know. Thank you, Claret. Thank you, Makioto, for that. That's very important to know how it's spread. And it's going to all make sense later. So let's go into the basic science of tuberculosis. So tuberculosis is a disease caused by a Mycobacterium species. So I hope you guys remember the species. If you do, you can just unmute and tell me the one that you know. Maybe I could, or you could type it in the chat because there's a lot to be covered this evening. And I'll just look at it as we progress. So there are a couple of species of Mycobacterium species, and the one that you should know is Mycobacterium tuberculosis and the avium complex. Why the avium complex? Because of patients who live with, who are seropositive and who are RVD positive. Yeah, somebody has talked about Mycobacterium bovis. Okay, so what is the risk factor for transmission of Mycobacterium bovis? It's very common by the way in our setup. Kenyatta serves the population from Kiambu and a large chunk of Kiambu, Thika, thereabout. That's the population served by Kenyatta. Yeah, milk consumption. So how would you get this in the history of somebody, like you're trying to think that the causative agent could be Mycobacterium bovis? What do you think would be the question that you'd ask in this kind of setup? Okay, so the kind of question that you would ask in this setup is, have their cows been vaccinated? You know, we live in Kenya, and in Kenya, people like to grease the law, or the guys who enforce the law are too lazy to do it anyway. So what happens is, normally a veterinary officer is supposed to pass by every home in a village to vaccinate cows. Yeah, when they are born, when you get a new cow in the home, they always come and they always ask for the vaccination book for your cows. And many Kenyans don't have this, so they end up like just paying kitu kidogo and they bypass this. So you could find an elderly mama who's living in uko Moshada. For those who don't understand, I'm talking about uko Ushago, like in the village. You could find an elderly mama or an elderly man or a young man who's a farmhand and he comes in presenting with signs of tuberculosis. There's another very important disease that's a bacilli, I think, that is also very related to cows. I think I should ask this one. Okay, I'll give you an assignment. Maybe you can go and read on transmission of how is cow farming important in infectious disease. There's one very important one that you will do in infectious disease. There's brucellosis. Okay, brucellosis, We're in Kenya, we're in Kenya, we're in Kenya. Brucellosis is a white man problem because it's a white man problem to some extent. Give me another one. Give me another one. There's another one. There's another very important one. Do you remember this one that formed heat-resistant spores in microbiology? They were heat-resistant spores. That's the clue. It was a bacteria that had heat-resistant spores. Do you guys know anything called anthrax? Yeah, so anthrax is there. Then there's something else maybe we could talk, maybe something else that you should also know is you should go and read about leishmaniasis and kind of try and find out the regions because it's very important. Normally it follows the milk bed. Like you'll hear some cases in Kiambu, hear some cases in Nakuru, very common around the Rift. You'll hear cases, it's very common around where people are doing a lot of grazing. And for the reason that you know, because you know what transmit leishmaniasis. So now, somebody has said Mycobacterium bovis, and I really like that. Thank you so much for that. So now you have the species. So our most important species to us is Mycobacterium tuberculosis. That is a facultative intracellular rod-shaped bacteria. And to detect it, you use special stains like Zn stain. In Zn, the acid-fast bacilli, they appear pink. But you know, Zn is very expensive, and there's an alternative stain called aramine rhodamine stain that where the AFB, the acid-fast bacilli, they appear reddish yellow on fluorescence microscopy. And it's very important to know these things. These are some of the things that, because you know, once these sessions that we have at this time, and we call them common sessions, they are very important. Why? Because when you are in that room for your end of rotation, I'm going to describe for you the setup, yeah? So you're going to, that day, you're going to be given a patient, you're going to clerk, you're going to come up to the department to present your case, yeah? So when you present your case at the department, you'll be presenting to specific lecturers, yeah? So let's say you land on a certain door. I won't mention doors here. I don't want to jinx myself, but you land on certain lecturers. They really know their stuff on tuberculosis. Many of them wrote the guidelines that are used in management within the country. So you land on that door and you do not know. You present your case, you think you've done a good job, which most of the time you might have. Then now the questions start to pour. So what is TB? Where does TB come from? And it's important to always build your basic science. Don't ignore those portions in your books. Just go through them, yeah? So aramine rhodamine is a screening kind of test. It gives a screening test. It's cheap, it's readily available, and it's used for screening, but Zn is diagnostic, yeah? So now let's go on to the next one. So I think it was Angel who talked about the risk factors about immunosuppression. Yeah, TB has risk factors. So you need to have a history of contact with high-risk groups. We live in Nairobi, Kenya. And in Kenya, in general, we are living in a center where TB is very prevalent, yeah? So you can't say that I've not come into, there's this thing, I remember I used to say it as well, I have not come into contact with anybody with TB. The patient reports not coming into contact with anyone with TB. It's not true. You take a mat every day. If you take a mat going home, if you take a mat going wherever, there's a guy who just spat out some phlegm on the road, high chances are you've come into contact with TB because we're an endemic area, yeah? So we are constantly in contact with high risk groups. So sometimes that thing of travel, it only applies when you're in the West, because in the West, if you read the books, they'll always, that their clinical vignettes kind of have this history of travel to maybe Southeast Asia or India or to Kenya or to Africa. And that's normally the risk factor. But for us, that's travel is not as important because we know that you can get it anywhere. Yeah. So you have those ones, contact with high-risk groups that we all have as a risk factor. But then now the things that differentiate it is in things like immune deficiency. Yeah. So somebody who is seropositive or living with HIV is at risk of getting tuberculosis. Somebody who's on corticosteroids or immunosuppressant therapy is also at risk of getting tuberculosis. Somebody who is using chemotherapeutic drugs. Very important. These are the things that have to come out in your history. And then there's nutritional deficiency, in particular vitamin D. Why is that? Why is that? Why is that a risk factor for TB? Has a very simple reason. Maybe I could ask. Yasmin, or is no, I don't. Is Yasmin in a position to talk to us about why they think vitamin D deficiency is important in tuberculosis?
Mhm. I don't know the reason for that.
Okay, that's okay.
Yeah.
The reason is
Yeah.
quite simple. I'm going to tell you guys this. So you said that the granuloma formed is caseating granuloma. Yeah, it's a caseating granuloma. Caseating showing that calcium is involved. Yeah, and what is the importance of vitamin D to us as it encourages the absorption of calcium in. I think it is some part of the ileum that you must know, by the way. So it is important to know that nutritional deficiencies also puts you at a risk factor. And I want you guys to go and read on the features of vitamin D deficiency, something called a rachitic rosary or the rachitic shaped chest. Yeah. They are the children who get rickets, but in adults, they get something else. Go read on that. Yeah. I also want you to, while you're reading, just try and peruse through something called renal osteodystrophy. These things are very important, and these are the things that they catch you inside there. So you have to know that the nutritional deficiency for vitamin D is important because of that. There's also diabetes mellitus for the same reasons. Okay, I think it's something like that. Yes, thank you. Osteomalacia in adults. That's good. Thank you, Terry. So diabetes mellitus is another very important risk factor. There's chronic kidney disease for the same reason that nutritional deficiency is a risk factor. Then there's malnutrition, of course. And then you get lifestyle factors, things like drug or alcohol misuse, homelessness or overcrowding, and people who are in prison or who are incarcerated. Yeah. I hope you guys keep these risk factors in mind. We have a couple of activities up on Bele. So this is the pathophysiology of tuberculosis. So why did I call tuberculosis the poor man's sarcoidosis? Because tuberculosis and sarcoidosis happen the same way. Only difference is the type of granulomas and the population that are affected. Yeah. So in sarcoidosis, the population that's affected is Caucasian. These are the guys from the West. Yeah. Developed countries. Yeah. Uh, but tuberculosis is here in the Far East and in the East. Yeah, it's common in developing nations, and it's something that you'll see in the world, and you have to know everything about it. Yeah. So individuals with TB infection, they transmit it by coughing, the contaminant that contains high pressurized aerosolized droplets. That's very important. Yeah. So these inhaled droplets by they're inhaled and they reach the terminal alveoli and they're taken up by the alveolar macrophages. Yeah. And there's a name given for tissue macrophages, but they're in the lung. You need to know them. I hope you guys do. If you know them, please type it in the chat. I don't want to really bombard you and we lose time. You have to know the tissue macrophage in the lung. So the microbacterial cell wall, they contain pathogen-associated molecular patterns or pumps. I think this will be labored on in third year and in immunology. And it's very important to know pumps in the mycobacterium cell walls are things like lipoarabinoman and lipomanan. They are very important things to know. And you must know them. You must know them. You really have to know them. That these are the pathogen-associated molecular patterns on the mycobacterial cell wall. Yeah, these are things that were taught by Dr. Barasa, and I won't repeat, but you need to know. And then now the alveolar macrophages, they recognize these pumps via toll-like receptors or TLRs. Yeah, and then pro-inflammatory cytokines are produced, and it is up to you. Please go and read on those pro-inflammatory cytokines. Yeah, make sure you are aware of which ones, at least when you're making a conversation. Because there you'll go, you present your history very well, very confidently, but what might do you in is you don't know things like the pro-inflammatory cytokines because they think it's so basic that you should know. And then there's phagocytosis of mycobacteria. But then, if you remember, TB has a way, TB among other infections, they have a way of resisting or avoiding death by phagocytosis, yeah? And they do this by inhibiting both the phagosome maturation and the formation of the phagolysosome or the fusion of the phagolysosome. Yeah. And then you will have, at the end of the day, the goal is you will have frustrated phagocytosis. Yeah. And then after frustrated phagocytosis, what happens is that anytime that you try and take up something like macrophages, they try and take up something and they are not able to break it down via phagocytosis. Eventually, what happens, particularly in tuberculosis, the bacteria continues reproducing within these macrophages that have taken it up, yeah? So they start to die. And when they die, mind you, there is a release of mycobacterial antigens. And the dendritic cells, they pick this up, yeah? So you remember antigen presenting cells, and a dendritic cell is one of them, yeah? So these dendritic cells, they take the mycobacterial antigens, and which are complex with MHC2, and they present it to naive T cells, yeah? Then after they present it to naive T cells, what happens is that these now T cells, they become activated, yeah? They become activated CD4 positive T cells, and they migrate to the focus of the infection. And as Angel has said, it is a type 4 hypersensitivity reaction. And then the activated CD4 positive T cells, they release interferon gamma. Then interferon gamma, it acts on the macrophages to enable bacterial killing. This one you have to know how. And it's a good read. You'll go and read, and these are the things that will help you make sense of TB. And then, TNF alpha is very much involved in granuloma formation. And then now you have the gone focus and the gone complex. Yeah? So gone focus is a granuloma that is typically located in the middle or lower lung lobes, while the gone complex is formed by the gone focus, regional lymph node, and the linking lymphatic vessels. Yeah, very important to know. So now, as I've said, I've given you a trailer into the types of tuberculosis. Think primary, think secondary. Yeah? Think primary is normally in a child and in a non-immunized child or adult. Yeah? It's very chill. Your immune system can fight with it. But then there's primary progressive, where this is somebody who was not immunized against TB, very common among in the West when they come into contact with now people from the East. So they get it. They were not, since they don't receive BCG in developed countries, they come into contact with it. What happens is that they get the primary stage. Some people can clear and get into latency, but then most people actually clear it and get into latency. But some people, for one reason or the other, they end up getting into a primary progressive state, where now you're having multisystemic manifestations of primary TB. And then the secondary TB. This is normally an immunocompromised fellow, yeah? So he's immunocompromised, and now what is happening is either had a latent infection has become reactivated, yeah? So now you're having this HIV causes a decline in CD4 T cell population, yeah? We talked about HIV last week. It causes a decline in CD4 positive T cell population. And what is happening now? We've just said how important the CD4 positive T cells are for the forming of the granuloma and the maintaining of the granuloma. Yeah. So now the CD4 positive T cells population declined. What happens to the granuloma? It starts to break apart. What happens to the mycobacteria? It's going everywhere. And normally, the preferred method of spread of TB is hematogenous, or miliary TB, because they look like millet granules. That is the most preferred way TB likes to spread to other systems, other part of the body, yeah, because the circulation is very linked, yeah, the circulation within the lung to the system, because you guys know about the azygos, hemiazygos system in the chest. It's linked between the inferior vena cava and the superior vena cava, and the relationship between the inferior vena cava and the portal vein. So if you just look at that, you can literally follow everywhere TB is going to go. Yeah, because of the azygos hemiazygos system, it can spread within the thoracic cavity. Because of the azygos, because of its connection to the inferior vena cava and the superior vena cava, you can have spread to the liver, and you can have a liver granuloma. It's a very common cause of a space occupying lesion within the liver. It can also go to the peritoneum or the peritoneal cavity, and you can be able to see what it will cause. You can find TB in the stomach because of that. You can find TB everywhere else. TB within the gut itself likes to spread through the lymphatic method because of something called gut-associated lymphoid tissue, where you'll have this TB getting to this area, doing what it does, and it can spread to now the MALT, which is the mucosa-associated lymphoid tissue. And I know you guys have gone through this again and again and again, so I won't disturb you with that. But just know, primary TB, secondary TB. What you'll see in the ward most of the time is secondary TB. Yeah, so this guy will have a history of being seropositive. he'll have one of the risk factors. Either he's incarcerated, yeah, either he is either he is living in a crowded area. There are crowded regions, and you can easily tell from the residents. You just ask somebody, be tact while asking, don't be pompous, while asking. We're all human beings, and everyone wants the best for themselves. So you can't go to the patient and just say, unaishi wapi, just being all rude and pompous about it. You have to be very polite and just be cognizant of the fact that this is a human being and say, yo, hi, where do you live? And then how is it like that? Then let him talk. And he'll probably give you everything you need to know without you trying to embarrass him or demean him. Yeah. So now you'll get most of those risk factors there. They could be seropositive, but don't just cling onto that seropositivity. Explore as many risk factors as possible. So now we're going to talk about the reason that we're here. And we're going to talk about how to clerk the TB patient. Yeah. Number one, the physician is a detective. That's one thing you have to know. What do I mean by the physician being a detective? You have to look for TB, and it must be evident that you have looked for TB. And there are things that you have to capture. So in the biodata, you normally find this is a guy, and he's normally unmarried, and he lives alone. Very common risk factor profile. I remember when we were doing pathology, Zuri Elizano told us, if you have an upper respiratory tract infection, highly likely you're looking, or an upper or a lower respiratory tract infection, you're looking at a single man who lives alone. And that we laughed at that joke, but it's something that you have to bring out in your history. And even when they ask you what made you conclude to this person having TB from his biodata, you just break it down like that, you really show it. And then the patient, you could also find a history of being immunocompromised, somebody who's seropositive, somebody who's on long-term high dose of corticosteroids. Yeah. And then you find out where he lives. He's living in an area that are overpopulated. Yeah. So, now we are, once again, we're a country of greasing hands. So it's quite easy for people to get away with these things in terms of ordinances and building ordinances. So you'll find a guy telling you how they live in their plot, and you wonder, no personal space at all. Yeah. And then most of the time you'll have this presenting complaint where they'll have a cough or shortness of breath if you're meeting them in the rest pod. But you might also find somebody who has abdominal pain, hotness of body, vomiting, and abdominal distension. Yeah. Let me ask, which kind of TB do you think that is? I'm going to call somebody now. Catherine Olga, please tell me, which kind of TB do you think would present with abdominal pain, hotness of body, vomiting, and abdominal distension? Yes. Thank you, Claret. TB peritonitis, yeah? That's very important to know. Which kind of TB do you think could present with a back pain, hip pain, and loss of function in either one or both of the limbs? Yeah, Pott's disease. Thank you so much. Which kind of TB would present with urinary symptoms? I would have given it a better name. Call it now prostate TB or TB in the prostate. Yeah, urogenital TB is nice but broad. And then, so that covers even TB in the testis. TB in the testis is kind of a very hard catch, just somebody that testicular mass that doesn't shine on transillumination, so it's opaque. That's good, guys. And now I'm going to ask you a very important question and a very key question that I want you to tell me. So you have seen a patient and your HPI, you have, okay, let me see in chat. So Pott's disease presents with back pain, hip pain, loss of function or weakness. So now this is an important question I have to ask you guys. TB causes something. There's a very important abscess that's caused by TB that causes the hip pain. What is the abscess called? I expect your responses on the chat, guys. Yeah, psoas abscess, a cold abscess. Thank you so much. Very important. So keep that in mind. These are the things that you go with and you present, and they're looking for these things in your history. Yeah. So in your HPI, this is where normally guys are caught. Yeah. Because you might have a very shaky HPI or a HPI that now will tell them this person doesn't know TB. We need to have a conversation about it to see. Yeah. So as I've just said, the physician is a detective. So when you're in the internal medicine ward, you're not in the surgery ward, yeah? You're not in the psych ward, you are in the internal medicine ward. The internal medicine ward requires you to think far and wide. And it wants you to really bring out why is it TB and not anything else, yeah? Sometimes you could be in the ward and you could, sometimes we're here and we're talking TB could be in any ward. TB could be in the endocrine ward. Have you guys heard of TB of the adrenal glands? I hope you've heard about it because I remember it used to be a very common spot. So TB of the adrenal gland and then TB otitis, very important thing to know. So now you have to be in the word. You have to show them beyond a reasonable doubt. Why is this guy thinking this way and it's not there anything else? Yeah. You have to say the patient has hemoptysis. A myriad of things could cause hemoptysis. Yeah. Once again, use my formula, indicate, or use the formula that you're comfortable with, like vitamin C, D, E. Yeah. So patient has come with cough, shortness of breath. Yeah. And the cough is associated with a product with the sputum that is bloody, and it's a small copious amounts of bloody sputum. And now you have to ask yourself, how can I say beyond a reasonable doubt that this is TB and this is not anything else? Because there's a couple of things that could cause that. If you follow my formula, vindicate, what you'll see is vascular. You could have a pulmonary embolism causing that, yeah? You get? You could have a pulmonary embolism presenting with that. Yeah. You could have an arteriovenous malformation presenting with that, a ruptured AVM. Yeah. You could have an infectious cause, like we all know that pneumonia normally has a stage where the cough, the sputum produced might be bloody. Yeah. It could be secondary to an iatrogenic cause, like the patient has had bronchoscopy. Yeah. It could be a congenital cause. Yeah. The patient is born with one of the Ehlers-Danlos, either type 1, type 2, thereabout, that cause weakness in the type 3 cartilage. So this guy could be having rupturing pulmonary hemorrhage everywhere, yeah, left, right, center. Yeah. You could have somebody with the autoimmune conditions like lupus, could have somebody with vasculitis. Yeah. You could have somebody with vasculitis, like once again, Wagner's. You could have somebody with good posture. So you have to show in your history, have you asked about these things? Yeah. Then you could have somebody who's maybe been exposed to a corrosive element. Yeah. Sometimes you have this guy, hemoptysis, and then you've ignored the fact that he works in an industrial plant. You haven't even asked him where you work. Do you use a mask if it's interacting with corrosive chemicals? Because it could be something corrosive. Yeah. You could also have somebody who could be having a malignancy of sorts because they cause hemoptysis. That's actually normally the first presentations, because now you have hemoptysis, you have weight loss. There's always a time to query malignancy, and you have to show that you really asked all these questions. Yeah. And you've narrowed it that this guy has pulmonary TB. Yeah. And then now you have pulmonary TB. Where am I going to go from there? It's to find out, is this pulmonary TB with any other TB elsewhere? So in your history, you have to bring out the complications of tuberculosis, as we've talked about. Yeah, we've talked about TB being multisystemic. There's TB meningitis. So let me ask somebody. Please unmute when I call your name so that we can talk. I do not bite once again. Maybe Salim can tell me, how do they think TB meningitis will present like?
Okay, maybe a headache. They're going to complain of a headache, stiffness of the neck, and yeah, I think, yeah.
That's a great job. Thank you so much, Salim. Yeah, you just have the classic symptoms of meningism, but what you would like to add is you'd like to add this person will obviously have an intentional weight loss. Yeah, you'd also like to add that this person might also have Night sweats. And I keep on telling you guys, go and read how night sweats come about, please. Sometimes I read and I read some of your histories and I can know that you understand why night sweats is very specific. Yeah, because somebody could be having diaphoresis, which is an autonomic dysfunction. It's not night sweats. Yeah, night sweats is drenching. How they will describe night sweats to you is that literally they feel like they are pouring buckets of sweat, that they have to wake up and change their bed sheets. The diaphoresis one, normally they'll tell you I'm sticky. Yeah. But this one, they'll tell you, I literally feel like I had a bucket of water poured on me, but instead of water, it's just sweat. Yeah. So know that. And then now maybe I could ask another question. How do you think TB, I've already told you how TB peritonitis and majority of the other TB presented. I just needed to hear the TB meningitis, so I think we can progress. So when you're really painting your HPI, try and follow the 6-step plan that I talked about. Yeah. Always try and talk about the 6-step plan. You get what I'm saying? When you're coming up with a history, you have to analyze your symptoms. Do a proper Socrates. And guys, read Hutchison's. You're getting better from what I'm seeing. You're getting better, but we're still a long way off for that distinction mark that God willing all of you should get. Yeah. So you have to always analyze the symptoms systematically. And there's a way for doing this in Hutchison. And guys, please go and read that way. Before you use things like breathlessness in the history, avoid it. Make sure you analyze Hutchison's. We are very British in terms of instruction. Nobody recognizes breathlessness as a presenting complaint in old English practice, yeah. And majority of these guys learned this way. So now, putting breathlessness as a presenting complaint it's damn near suicide. So you have to know about shortness of breath in RESP symptoms. You have to know about difficulty in breathing. And you have to know that shortness of breath and difficulty in breathing, they only have associations in heavy. It's either orthopnea, paroxysmal nocturnal dyspnea. Because majority of the time, what they'll describe to you is they'll be describing exertional dyspnea to you that later became paroxysmal nocturnal dyspnea and orthopnea. And those are the only associations of shortness of breath and difficulty in breathing. Yeah? And as I've said, in rest, keep it to shortness of breath. So now these guys who have abdominal pain, talk about that abdominal pain. Why is that abdominal pain not gastroenteritis? Why is it not gastritis? Why is it not hepatitis? Why is it not trauma? Those have to be seen in your history. Yeah. I hope you guys are getting this. Yeah. Somebody with urinary symptoms, because once again, I've said the picture is a man. Why is it not prostate cancer or benign prostate hyperplasia? You see, the good thing is with somebody who could present like that to the renal ward, it's quite easy to have a good differential because prostate cancer also metastasizes to the back, the spine. And it's very important to know that. So HPI follow the 6 steps that we have talked about time and again. Please follow the 6 steps. So now let's do an activity, yeah? So I'm going to call one of you, and one of you is going to read this. Ignore everything in brackets, and I'll be here to assist you through this. And after we talk, we're going to talk about, with that person who's going to read, we're going to talk about the salient features that they think they see in this short clinical vignette. Maybe I could ask. Mohammed Hafsa Abdi. Okay, I don't think Mohammed is available. Maybe I could ask Angel, could you just please read for me this activity?
Okay. PM is a 46-year-old incarcerated man and a known RVD patient. He was diagnosed 5 years ago, but he's non-adherent to TLD therapy. He came in presenting with cough and chest pain for 2 weeks. The cough, it was gradually progressive as he went from 1 episode of productive cough per day to 2. There were no exacerbating factors which came to mind. An antitussive prescription from the prison infirmary gave him very little relief. He reports the cough would occur at any time of the day. The cough was associated with a bloody sputum, approximately 20 milliliters per episode. There was no history of palpitations, orthopnea, PND. There was a positive history of recent contact with a TB patient while in prison. There was no history of trauma, no history of photosensitivity, joint pains, rashes, asthma. There was no history of SCI inhibitor, SCE inhibitors, NSAIDs, BBs, no history of any cancer in the immediate family. However, there's a positive history of night sweats, slight fever, weight loss, and appetite loss. For the chest pain, the pain was occurring across the chest with no epicenter. It was sudden in onset, occurring when breathing rapidly while partaking in physical activities. He described the pain to be burning in sensation. There was no associated symptoms. He would rest to bring down his respiratory rate. Resting to bring down his respiratory rate relieved this symptom. He rated the pain a 5 to 7 out of 10. There was no history of any cardiac events, trauma. There was a positive history of contact with a TB patient. There was no history of trauma, no history of photosensitivity, joint pains, rashes, asthma, no history of heartburn when lying down. Decreased or frothy urine. Is that no? No history of heartburn when lying down. Diabetic mellitus, decreased or frothy urine output. No history of SCE inhibitors, NSAIDs, BBs, no history of any cancer in the immediate family. However, there's a positive history of night sweats, slight fever, weight loss, and appetite loss. There was a positive history of smoking, but has ceased since incarceration, which was 6 years ago. He has, positive history of alcohol intake, also ceased 6 years ago.
Okay, so now we've talked about this guy. So Angel, please stay on. What do you think are the salient features that would make you say that this guy has pulmonary TB?
Okay, the salient features. Do I start from like the biodata going downwards?
Yes, please.
Or for the biodata, I would say the fact that he's a man and a known RVD patient, and also that he's non-adherent to his therapy. Also that he's incarcerated. That would hint towards TB. Then for the cough, I would say the progression of the cough, it was worsening. He said it went from 1 episode of productive cough per day to 2. Then no antitussive prescription from the prison gave him any relief. Also that the cough would occur. I feel like I'm going to keep mentioning everything. So let me, the cough was associated with a bloody sputum. Positive history of a recent contact with a TB patient while in prison. Yes, then a positive history of night sweats, slight fever, and weight loss.
That's good. That's good. Thank you so much, Angel. What you've said is good. I'd like to just add one thing you missed, and that was the time, 2 weeks. Normally very acute to subacute in presentation. Yeah, that's important to pick. But thank you so much, Angel. You've picked all the salient features that would say that this is pulmonary tuberculosis. Yeah, and now, how do you rule in and rule out? Because I know that's where you guys are. It's challenging. Even us, when we started off, I can tell you for free, our histories were bad. They were terrible. And after that time for the strike, they got even worse somehow. But we survived, and we're going to tell you how to survive. So when somebody tells you they have a cough and chest pain. Yeah. And they could have something like shortness of breath. Your brain will automatically start cooking up a myriad of things that I've told you. Use Vindicate. I like Vindicate. It's much more straightforward. So you have Vindicate. Yeah. You know the vascular causes that could cause this cough. Yeah. Something like a pulmonary embolism. Yeah. Then you know something infectious that could cause this, something like bacterial pneumonia. Yeah. You know, now you know something else. You know something like viral pneumonia. You know, COVID. Yeah. Those are important things to know. And how do you think I would rule out COVID in such a patient? Let me ask maybe. How would you rule out COVID? Nura Sahir. I think that's how it's pronounced. I don't know. But please tell us.
I'm not sure about that.
You're not sure how you'd rule out COVID. Do you remember during COVID when they used to tell us that the first sign is that they get altered taste and loss of smell?
Yeah.
Do you remember that
Oh,
altered taste?
okay.
Yeah, that altered taste and loss of smell. That's how you do it. Yeah. So keep that in mind, guys. That's how you rule out something like COVID. Yeah. And then now we have a neoplasia, something like bronchogenic carcinoma. What are the risk factors for bronchogenic carcinoma? Majority of the bronchogenic carcinomas. What's the risk factor? Let me find out. Etemesi Masi, could you tell me about the risk factors for bronchogenic carcinoma?
Could you pardon?
Uh, could you tell me the risk factor for bronchogenic carcinoma?
Um, one of them is, could you say smoking?
Yes, smoking, just smoking. That's all I needed. Smoking. That's the most prevalent risk factor. But you guys should know, being good students of pathology, that there are some lung tumors that are not associated with smoking. Yeah. And it's important to know. And it's very important to know that. Yeah, there are things that are related to asbestos. Asbestos causes a particular tumor, which is that one you must know. Which tumor does asbestos exposure cause? Ah, very nice, mesothelioma. You guys are good students of pathology. Yeah. Some of us were bad students of pathology, so we're not judging. We are here for you. So you have to know that this is how you look at things. And you said smoking. But this guy says his smoking history and it gives you 2 pack years. Do you think that's significant, guys? Margaret, do you think its 2 pack year history is significant?
I, I don't think it's significant.
Thank you so much.
Yes.
Yeah, thank you so much, Margaret. It's not significant. So that kind of puts a question mark on our neoplasia diagnosis, but all the same, cancer is ever changing. So that's why it's a very good thing to have. Then for drugs, you see, there's been good rule out. Why do you think ACE inhibitors were ruled out? Give 2 examples. When I call out your name, you give me 2 examples of an ACE inhibitor and what does the adverse effect that it causes? Mark, could you tell me about ACE inhibitors? 2 ACE inhibitors and the adverse effect it causes.
One is captopril and lisinopril, and they cause coughing, and angioedema, change of taste, pregnancy.
But you're okay. I just needed the cough.
Oh, yes.
The angioedema, you're good. But angioedema has other causes that are more important in the world that you guys should know. So now,
Okay.
now you have ACE inhibitor use. Why do you think NSAIDs were rolled out? Maybe I could ask somebody. You give me an example of an NSAID and why it was ruled out. Maybe I could ask Sadia. Could you tell me an example of an NSAID and why do you think an NSAID use was ruled out?
Okay, an example is ibuprofen, but I'm not sure why NSAIDs have been rolled out.
Have you heard NSAIDs causing something called gastritis?
Yeah.
And do you guys know that gastritis later progresses onto something? Yeah? It
Yeah.
progresses. Yeah?
Yeah.
And then that thing is associated with the acid production. Yeah? And acid itself, the increased acid production causes something very important. It causes reflux. Yeah? And because of the reflux of the acid, there is a tickling, for lack of a better word, of the phrenic nerve, and somebody coughs. So it's common. People with hyperacidity, obese people, people who are pregnant to cough. Yeah. Then now, another thing that's very important to ask, this person has been in prison. And as again I've said, incarceration is a great risk factor. Don't call them prisoners, number one. It's just be tactful, treat them like they are victims of circumstances, although some are not, but like be tactful when you talk to them. That's why I've used the word incarceration. I've brought it in very purposefully. You have to call the guy, he's incarcerated, yeah, so that you don't trigger him. That's how they don't talk to you. Yeah, sawa. So I think we've milked enough of that. So we're going to go on to activity 2. So let me ask. This is a simple question. This is a very simple question. Maybe I could have Bet Thomas Kiprotich read this for me.
Activity 2. A 45-year-old male presents to the clinic with a 3-month history of persistent cough, night sweats, and an intentional weight loss of 10 kgs, 22 pounds, I think. He immigrated from Southeast Asia 2 years ago and has not seen a physician since. He denies hemoptysis but reports occasional low-grade fevers. His past medical history is unremarkable and he takes no medication. He works in a crowded factory environment. On physical examination, his temperature is at 7.8 degrees Celsius, 100 Fahrenheit. Blood pressure is 120/80 millimeters of mercury. Pulse is 88 per minute, and respiratory rate is 18 per minute. Auscultation of the lung reveals bilateral crackles in the upper lobes. A chest X-ray shows cavitary lesions in the apical regions of both lungs. Laboratory studies reveal a leukocyte count of 8,000 millimeter cubic, hemoglobin of 13.5 grams per deciliter, erythrocyte sedimentation rate of 60 millimeters per hour. Sputum samples are collected for acid-fast bacilli, smear, and culture. Which of the following is the most appropriate initial diagnostic study to confirm the suspected diagnosis of active pulmonary tuberculosis?
What is the answer, guys? Okay, so let me prepare you why I put this question. I know majority of you, there's always that small subset that is reading ahead for end of year, and that's good. I'm not shaming you. Lord knows I wish I had. But let me prepare you. The department is moving away from asking these questions that are like, what is anemia? And such questions. These are the questions that you'll get 100 of them for 2 hours. Yeah. 100, 150, 2 hours. And you get these long questions, and that is the thing that they'll be asking. So you have to read and you have to prepare. So as you're reading, know that they're going to test your clinical knowledge even in your MCQs. Yeah. So you have to really know some of these things. Yeah. And I'm going to tell you for free. Sisi tulikuwa tumebeba, I know you guys know that video, tulikuwa tumebeba answers kwa file. Ati tumesoma past paper. Butua ilitupiga tujaamini. So be sure to have read and to have knowledge. Like from this, what do you think would tell you that this guy has TB? Maybe I could ask somebody. Uh-huh. Maybe I could ask. What do you think why would you think this person has TB? From the short clinical vignette that we've been given here. Maybe I could ask Ida.
Yes.
Why do you think this guy could be having TB?
Okay, so some of his symptoms that point towards TB are we have the persistent cough, the night sweats, the unintentional weight loss, and also he's an immigrant from a geographical region that has high incidences of, that has a high number of people with TB. He also works in a crowded factory, which is a risk factor. What else? The cavitary lesions in the apical regions of his lungs, according to the X-ray, could also point towards a complication of long-standing TB. Yeah, that's about it.
And that's okay. Thank you so much, Ida. So now that's very good. Those are some of the salient features that are there. So for the question, I've left you guys to go and read because it's something very easy. And I'm going to give you guys a clue. It's not tuberculin skin test. You don't use that for active infection. What do you use tuberculin skin test for? Yeah, latent TB. Yeah, thank you so much, Victoria. Yeah, the answer is latent TB, used to check for latent TB. So what do you think they use for active TB? Okay, so have you guys checked? Yeah, thank you. Those mambo sputum culture, sputum staining, that's what I need. Those are the hizo ndo majibu. Very good. Big up to Yasmin and everyone in the chat that's answering. So that's how you check for active pulmonary tuberculosis. So now for this one, I'm going to give you this one. And when I share the slides, when I upload the slides on the drive tonight, go through activity 3. And I want each of you to pair up or within your very own group discussions. You will discuss this question. I want to see your reasoning because this week the facilitators should be taking you through how to approach history taking from this aspect. Yeah. So in terms of investigations and all that. So activity 3 is an assignment and it's really good. So ensure that you just go through it. So for activity 4, maybe I could have somebody read activity 4. This is very important because this ndo ile jokes unaona blackout. So it's very important to just have an idea of what's happening. So maybe I could ask somebody to read for us this history. Maybe I could ask, who's willing to volunteer before I ask? Guys, as I've said, I do not bite. Oh yes, Linda, please unmute. Go ahead and unmute.
So SM, 23 years old, lived in Meru, a student, date of admission 14 June 2024, presenting oh, sorry, I'm presenting SM, a 23-year-old male who lives in Meru and is a student, was admitted on 14th of June 2024. The patient came in complaining of lower limb weakness for 2 weeks, the HPI. The patient was fairly well 2 weeks ago prior to admission, presenting with weakness. The weakness generalized, extending from the foot to the thigh. It started as a feeling of using a lot of energy to walk. It was gradual in onset and had no specific pattern and had no pattern with activity. There was associated tingling, which he described as a burning sensation. However, no pain, no skin rashes. The weakness was progressive to a point. The right limb was weaker than the left. With time, he reported that he needed assistance to even wake up from his bed. A few days later, he could not feel the sense of touch on both of his limbs, all the way from the foot to the hip. There was no history of eye pain, visual disturbances, no history of gastroenteritis, eating uncooked meat, no recent upper respiratory tract infection. Of significance is that 1 year ago in September, he was experiencing back pain. It was located at the mid-back, gradual in onset, sharp in nature, and non-radiating. He described it as an on and off pain that was worse at night while sneezing or coughing and sitting down. It was alleviated by taking diclofenac and also placing pillows on his back while sleeping at night. He rated the pain a 6 out of 10, and it will awaken him from sleep and interfered with his daily activities. He has no history of trauma, an intentional weight loss of 7 kgs done from 65 to 58, no urinary or fecal incontinence or retention, no history of drug use, no history of fever, no history of prolonged use of glucocorticoids, no underlying malignancy, no history of any invasive spinal procedure. He reports of history of cough, night sweats, fever, or TB treatment in the last year. However, of significance is that he was at a training facility in Kisumu that was crowded and they had to sleep in a hall with close to 50 people. The ventilation was not good enough. He had a friend there who he reports had a chronic cough and later died due to TB. He has regained sense of touch at the sole of the feet, however, not at the other areas of the limbs. So far, imaging has been done. He's on medication, awaiting abscess drainage. Rule out. Okay. Yeah. Yes, I've finished.
Thank you so much, Linda. That was good. So far, what do you guys think that this guy has? What do you guys think this guy has?
Pott's disease.
Thank you so much. Thank you so much. That's what this guy has, yeah? And this is how you will encounter these cases in the ward. And be sure to just approach them with the tact that when you're in a ward, open your mind. The one thing I can let you guys, like I can tell you guys for free, is this disease called tuberculosis is very multisystemic and it comes in ways you do not expect. Yeah. So you have to be well aware of your tuberculosis and the pathology that it causes. And you should be able to answer those questions and pick it out from the history that quickly, wow, this is POTS. Yeah. So you should be able to also know and have great knowledge of other systems. Yeah. Know your cardiology, know your neurology, know your pulmonology, know your endocrinology, know your gastroenterology. Make sure you're well conversed with those. Yeah, you're conversant with all those systems, and you're able to give a response to the lecturer when they ask you questions like why. Because we can teach you how to organize your history, but we can't teach you how to answer the question why. Yeah. And that's all what they'll be asking that day. It's why. Why did you ask? Why did you ask? What were you thinking? Yeah. They can turn that exam into 10 minutes of you spewing your history, 35 minutes of you answering questions back to back. Yeah. So be sure you're well aware of that. Yeah. Somebody has said POTS. Thank you so much. Okay, so we're going to talk about the management of TB, and I'm going to make it really, really quick. Yeah. So, what do you guys remember about the drugs for TB, the anti-TB drugs? Please tell me a few. If you can type it in the chat, well and good, but if you can unmute and speak, that would be awesome. Etemesi Masi, maybe you could tell me about the anti-TBs.
We have first line and second line drugs. For first line, we have pyrazinamide, rifampicin, streptomycin, erythromycin, I guess.
I want you guys to cook. Stop making life complicated. Like it's too early to make life
No,
hard.
it's not erythromycin, it's ethambutol.
Yeah,
Yes.
it's a ethambutol. And I want you guys to,
Then
you see the way something has been said, RIPES or RIPE. That's what I want you to know for now before you get on to second line. And why do I want you to know this? What is the adverse effect of rifampicin? It had a very specific adverse effect.
the urine, the color
Yes. Thank you.
changes, it becomes red.
Yeah, what about ethambutol? It had a very specific one.
I think the eyes.
Yeah, there's visual disturbances. So I'm going to tell you guys this. Also, isoniazid and pyrazinamide also had a very specific adverse effect. And what I'd like to tell you guys is when I was in the ward, I was clerking a patient. At that time, I was clerking with David. I think he's here. So we were clerking this guy, Patrick Atiku. I cannot forget his name. So we were clerking Patrick Atiku. And we were just there talking with Patrick. We're like, you guys, it was probably our second or third week. And we talked to this guy. We're taking his history. We're like, man, we're on a roll. And he starts telling us he has orange discoloration. He actually described his urine as it looked like ilikuwa inakaa damu. We didn't know that it was like a dark tinge of an orange. And then Pia, he started talking about his sweat as well, has been leaving like orange stains on his shirt. And he starts talking about tingling of his feet, and we associate it quickly with maybe it's due to the swelling, the edema that he had on his feet. And we are like, wow, we have cooked. We're that guy. So we go outside and we sit through and we're thinking through the history. And we start asking ourselves, wait, this guy has talked about anti-TBs. Actually, it wasn't even us, it was one of our friends. Comes and points out, yo, see, umesema he's on anti-TBs. You guys remember rifampicin? And we just laughed there because we knew, had we presented ourselves to a consultant that day, we were to lie to ourselves to go to a consultant, because by the way, what they don't tell you is if you pick the right day for the consultants, you can go to the department and you can go and present your histories to them. But we imagined that had we gone to the consultants, that day would have been cooked, would have been done for. So know these drugs, know the adverse effects, know what they cause, know how they do it, know what affects them in terms of other drugs that are comorbid. Maybe one thing I'd like to add to is a common MCQ question. So the common condition that's why I've given you this guideline here as a hyperlink, and when you have time, please go and read. There's normally a co-infection. Patients who have TB and who have HIV. What do you think is normally changed for these patients who have TB and HIV? What do you think people are trying to avoid? Maybe I could get some answers in the chat. So have you guys heard of something called immune reconstitution syndrome? If you have not, be sure to read on it. Oh, wow. Salim, could you tell me about immune reconstitution syndrome?
Okay, so we had a patient who was RVD seropositive, and he was also newly diagnosed with TB. And the registrar asked us if it was okay to start the anti-TB drugs, then akatuambia we read further. So when I researched, it was saying you need to delay before you start anti-TB for like 2 weeks, because it will lead to your iris ambayo inaitwa immune reconstitution inflammatory syndrome. It's like an inflammatory system where, because of it's just the immune system. It's believed it's because the immune system imekuwa restored, and it will worsen the pre-existing condition. And the stimulus can be anything. Can be your TB, the CMV, the SLE, and it develops, I think, a few weeks after the ART initiation. So you have to the thing was, alisema first you administered anti-TB for 2 weeks, alafu ndo uendelee na ART to prevent hiyo.
That's Salim.
That's all actually.
That's more than enough. So there's normally a delay in administering some medication because you want to find out how can you prevent an immune reconstitution inflammatory syndrome. And I want you guys to go and read on that. And once you read on iris, I want you to give me a small write-up on iris. Just my usual email. I'm reading through all your write-ups and I'll be sending responses by Friday. So please read up on iris as well. And treatment of TB meningitis and how long do you delay in somebody who has TB meningitis with comorbid RVD. And I want the write-up. Yeah. So I think that's about it. We thank God. So any questions? If you have a question, just please unmute and ask.
Okay, I have a question. If the presenting complaints of the patient are pointing to a very, maybe let's say they have all the classic, like a classic triad pointing to a specific disease, do you still have to rule out other diseases? Like, for example, if it's only a cough, it has so many causes, but let's say it's a cough and something else and another thing that's totally pointing to a specific disease, would you still have to rule out all the other causes for each presenting complaint?
Thank you so much for asking. That's a lovely question, Maggie. And just stay unmuted because I'll ask you a couple of questions in my own. Give me an example of a classic triad.
Okay, I'll give for meningitis because I'm in the CNS ward right now. For meningitis, you'll have the neck stiffness, headache, fever, and also an altered mental status for the triad.
And then I'll ask a question. Have you read up on subarachnoid hemorrhage?
Not yet.
Subarachnoid hemorrhage also causes meningism. There are a couple of things that cause meningism. In internal medicine, that's why I put this on purpose. The physician is a detective. In internal medicine, the diagnosis isn't even important. It's always about the differential, yeah? They'll always be rambling about the differential. That's what matters to them, yeah? So you have to rule out, because there are a myriad of things that can cause all those things that you're saying. If somebody just takes the time, like I've already taken the time, we've talked about subarachnoid hemorrhage causing meningism. Yeah, there are also causes of subarachnoid hemorrhage. Yeah, there are things like hypertension, berry aneurysms in autosomal dominant polycystic kidney disease, could be Ehlers-Danlos in people who have vascular malformations from when they were young. Then that's already vascular, we've cooked. Yeah, then infectious, you have meningitis. Yeah. And you could also have encephalitis on its own or meningoencephalitis because of the altered mental status that you brought in. Yeah. Then now, what is causing the meningitis? Is it bacterial? Is it viral? So now you have to ask about the fever. Was the fever hot to touch? Was the fever warm? Yeah, viral or bacterial? Yeah. Has the patient had any history of an upper respiratory tract infection? Bacterial? Yeah. Has the patient had a history of maybe contact with somebody with TB or similar symptoms? Is it Neisseria meningitidis? Yeah. So those are all the things. Then neoplasia, there are some space occupying lesions, things like frontal meningiomas that occur in this middle-aged to postmenopausal women that can also cause some features of meningism due to irritation of the leptomeninges. Yeah. Then that's already neoplasia. We cooked till neoplasia. Then we go to iatrogenic. There are some iatrogenic causes of meningism. Yeah. So you always have to things like biopsies. Has the patient had a biopsy? So that's why you always have to rule out, because in internal medicine, you can never be too sure. You always have to have a list of differentials. I hope I've answered your question, Margaret.
Yes, you have, but maybe just a follow-up question.
Yes.
If okay, my question, I've understood everything you've said, but in cases maybe chest pain on its own has many causes. Coughs on their own have many causes. But if someone is presenting like with three, from what I've understood, from what you've said, we'll now just explore the causes of the differential that we have in mind.
And then another thing that I would like to point out, and I think I'll point out the more you guys continue to present your histories, the more you guys continue to present your histories, it's important to know that how you organize your history also matters. So with chest pain and things like those, they have causes that you normally, you guys have been taken through the 6 things and you've talked about relevant associations, yeah? So in relevant associations, that's why you normally ask any other possible thing that could cause that individual symptom. You don't get into, I've seen some of you get this bad habit where you get into risk factors per presenting complaint, and don't do that. There's a place for that. And I'll have to explain this by taking you through my own clerking process. So I'll be sure, I think the guys that will meet in cardiology, I have a couple of my histories still lying around. I'll make sure I'll just take a photo and I'll walk you guys through how you organize your history. And maybe I'll try and talk to everyone here, and we'll try and show you guys how to organize it. Because I know what you're asking and I know what you're implying. It's very easy to get too overexpansive with one PC. So what you try and do, you try and start from most relevant association to least relevant association while you're there. And then now your important positives and negatives, you should be thinking broad-based. You should be thinking like, what could cause this picture that I'm seeing? Are they part of the same pathophysiological process? Yeah. I hope I've answered your question, Margaret.
Yes, you have. Thank you.
You're welcome, Margaret. So somebody has asked why I ruled out NSAIDs in activity 2, and I told you about gastritis, yeah? So gastritis is one of the causes of hyperacidity and reflux. So you have reflux. Reflux is tickling of the phrenic nerve, and the phrenic nerve is tickled, you cough. So it's very important to ask about NSAID use. Even obesity is a risk factor for cough. It causes cough by the obesity, pregnancy. Anything that causes hyperacidity and reflux causes a cough. You're welcome. Any other question?